Hey, this is Jonathan Parker, and I'm going to record a video today on non-invasive ventilation. This is going to be the first video in a series of videos that we're going to do on critical care medicine 101, or fundamentals of critical care medicine. The more we talked about, or more we talked to our interns and people, we realized that family medicine really is sometimes missing some fundamentals in critical care medicine. And as much as we believe that family medicine belongs in critical care, belongs in the ICU, especially in rural places and in rural places in our state in Alabama, where they need to be in the ICU to take care of patients, we need to make sure that we are setting the bar high and that we can really work at a level of excellence and really work at a level where we can excel. So non-invasive ventilation, other than antibiotics, are probably one of the biggest things that we can do for patients in order to help them in the largest way. So we find that in order to, we probably are intubating patients that could have been put on BiPAP, and if the intern or whomever is taking care of the patient would have known how to use BiPAP appropriately, and it goes beyond just the generic 10 and 5 that the respiratory therapist will put them on, that we probably could have avoided intubation in the first place if we just knew what was going on. And the thing is BiPAP is extremely easy. It is very, very simple. So here's a short video today to talk about the fundamentals. So let's back up and think about what we're actually talking about. And we're talking about respiratory failure. And there are two kinds of respiratory failure. And I'm using a whiteboard app, so forgive me if my writing is even worse than it typically is. But type 1 failure is an oxygenation problem without hypercapnia. Type 2 is a CO2, this is a ventilation problem with hypoxia at times. So your type 1 failure is an oxygenation problem, your type 2 failure is a ventilation problem. And these are the things that we're going to keep in the back of the mind, and these are the things that we're trying to treat with BiPAP when we actually use BiPAP. Your type 1 patients are going to be your ARDS patients, your pneumonia patients, and your CSF patients. CSF patient is probably the most common type 1 patient that we actually see and treat, and it has a very, very good indication for using BiPAP. Your type 2 patients, your ventilation patients, are your COPD and asthma patients. And most commonly, this is going to be your COPD exacerbation. That's what we're actually going to see. So what does BiPAP actually do? BiPAP blows air. It blows air into the oropharynx, into the airways, into the lungs, and it blows air typically in two pressures. I mean, that's what it does. It is a bimodal pressure support machine. So it blows air into the patient's lung through a mask. So the two pressures that it's going to blow is going to be the EPAP and the IPAP. So as it blows the pressures in, the patient is also inhaling and exhaling. So as the patient inhales into the lungs, this is the pressure that they're going to get. They're getting that IPAP. So as they inhale, they're going to get this full pressure of the IPAP pressure that you're setting. And as the patient exhales, they are breathing against a pressure. They're breathing against an EPAP pressure. They're breathing against this pressure that is constantly blowing, even if the patient is exhaling. So this is the equivalent to PEEP or CPAP. So if you just had a CPAP machine, then it's the exact same thing as EPAP on a BiPAP machine, and it's the exact same thing as PEEP. The air that continuously, that end expiratory pressure, the pressure that's blowing even at the end of expiration for a patient. That is what BiPAP is. That is it. As they inhale, they get a pressure called the IPAP. As they exhale, they still get a pressure being pushed against that exhalation, and that is called EPAP or PEEP or CPAP. IPAP is also known as pressure support if you think about it in terms of mechanical ventilation. And the BiPAP machine has three main modes, which we've talked about: EPAP, IPAP, your FiO2, and there's also a backup rate. The backup rate is the least important of all of this. And you can generically set the backup rate at 15 or 16 in the same way that you would set it generically for mechanical ventilation, but it is the least important setting on the machine. Because remember, if a patient is sedated, then they are not, that's a contraindication to actually using BiPAP. Despite, there's some discussion and some controversies out there about if that's always the case, but technically a patient needs to be awake and need to protect their airway if you're going to put them on BiPAP in the first place. So these are going to be your three main settings that you're thinking about: your EPAP, your IPAP, and your FO2. Your EPAP, which is the same thing as PEEP, which is the same thing as CPAP. So this is the pressure that they're going to blow against even as they're exhaling. This is the most important pressure if you're dealing with an O2 problem. So your CHF patient, your patient with pulmonary edema, your patient with pneumonia, this is fluid in the lungs. If you have a patient who has fluid in the lungs, it's the EPAP that actually pushes out that junk in the alveoli and pushes it back out of there in the exact same way PEEP does in your ARDS patient who's on mechanical ventilation. So if you have a patient who is on mechanical ventilation, what do you do for an ARDS? You want higher PEEPs because it actually pushes that fluid out of there. In the exact same way, a patient has an oxygenation problem, it's all about the EPAP. IPAP, on the other hand, which again, remember, it's the same thing as pressure support on a mechanical ventilation. This is all about your ventilation. So your COPD in your asthma patients is about IPAP. So if you have a patient on COPD, you want them to have low EPAPs and high IPAPs, because by the time they're on any kind of mechanical ventilation, they're probably starting to tire out. So they're going to need respiratory support, which is why you're putting them on BiPAP in the first place. But they need the pressure as they breathe in, but they need very, very little pressure as they breathe out, because that gives them time to breathe out. You want your COPD patient to be able to exhale all of that CO2, because, of course, that's the whole pathophysiology of COPD in the first place. So you want, in those patients, it's all about the IPAP. So you can start a COPD patient at an IPAP of 5, and you can go up to 15 to 17 as you need to correct their CO2. Maybe 5 does it. Maybe 5 will fix their CO2 problem. Maybe it doesn't. Maybe you have to continually go up as you get that ABG back. EPAP, on the other hand, is that it's an O2 problem. You start them at 5 and you go up to 15 or 17 in order to correct their O2 problem. Your FiO2 you can generically put at 100% and you can titrate it down as need be. In a COPD patient, maybe you only need 40% because, again, it's not an oxygenation problem, it's a ventilation problem. So you put them on, maybe you put them on an EPAP of 10, maybe an IPAP or a EPAP of 10, and maybe you only put them on an EPAP of 2, and it's written IPAP, EPAP, and then you write your FO2. So your COPD patient, maybe you start them at 10 and 2 and 40%, and that's all you need. But if you got a CO2 back that was continually high, this is the number you're going to go up on. If they had an oxygenation problem, this is the number you're going to go up on. So as you get the ABG back, that's how you actually adjust the ABGs. All you have to remember is EPAP is about your O2, IPAP is about your ventilation and CO2. So that is BiPAP in a nutshell. So a quick summary in your type 1 respiratory failure with pulmonary edema, your CHF patient, it is an oxygenation problem. You're thinking about EPAP. You want to adjust the EPAP. You can start at 5 and you can go up. Typically, you're going to do 100% FO2. You can titrate it as needed, but it's an oxygenation problem. Start them out at 100% FO2. Put them on 5 to 10 of EPAP. Don't put them on any or very little IPAP. Put them on 100% FO2. Your type 2, your COPD patients, which is your CO2, your ventilation problem, it's all about your EPAP. Your IPAP, sorry. You want to start at 5 and you go up, and you can start at 40% of FiO2 because, again, this isn't a oxygenation problem. It's a ventilation problem, and they do need support, but they shouldn't have a problem oxygenating is when they had the support and they're not tired. One thing I did want to mention, a local hospitalist that serves as one of our attendings who does a lot of mechanical ventilation and vent management in critical care medicine typically starts at 16 and 4. Why 16 and 4? Well, the 16, if you remember, these are poor pictures of lungs, as we actually breathe in, the plateau pressure that the alveoli actually sees, we want between 20 and 30. So when you intubate somebody, and you intubate them and you pick a tidal volume generically of 500, and then after you pick that generic tidal volume of 500, you look and you see what the plateau pressure is, because that's actually what the alveoli see. The peak pressure does not mean anything. And on our vents, plateau pressure is almost impossible to see, impossible to find, so you have to search for it. But in an ideal world, you would want it between 20 and 30. So in the exact same way, your inspiratory pressure, he starts at 16 because ideally, if you're going to max them out on what you would max them out on, it would be 20, right? That's what you would want the lungs to see. You want to push 20 millimeters of mercury actually into the lungs, but the mask doesn't handle it. So it generically chooses 16 to max it out. And again, a very, very low EPAP, because this is your typical type 2 COPD patient, and you want them to have as much time to exhale as you possibly can. So that's why 16, which is also why you typically will max out at 16 or 17 millimeters of mercury, because the mask just can't handle anymore. And if a patient needs more support than that and they're still not doing well, then they probably need to be intubated anyway. So that's pretty much it for non-invasive ventilation. Hopefully it's short enough to grasp. It's a very, very easy concept, and if we just continue to use it and you try it, we can probably eliminate a lot of intubations that we're having to do ourselves or call PALM for. So hopefully this is helpful, and we'll see you on our next video.